Thank you for joining us today. I know for some of us on the West Coast, it's earlier than it is on the East Coast for sure. But we're so glad that you're joining us today. My name is Dr. Bridgette Wiefling. I am the Chief Medical Officer and Transformation Officer for Cope Health Solutions. We are very excited to bring to you a group of thought leaders today to discuss New York Health's Rural Health Transformation program and how we're all sort of beginning to crystallize around the ecosystem of funding opportunities that are coming out nationally. How do we marry those opportunities with New York State's transformation agenda and think about not just this moment in time with grant funding and what a grant can do, in the immediate year, but how do we actually use these and leverage these opportunities across the different braided funding opportunities that are out there to drive sustainable transformation. And so you're going to hear from a group of us that are down in the weeds, but for those of you who are a little bit less familiar with Cope Health Solutions, we are a national tech-enabled company. We do consulting and we work very closely with federally qualified health centers and rural health hospitals and health systems, as well as community partners, to think about and design value-based care strategies. And more importantly, we provide the technology and the platform that helps to operationalize those strategies for success under emerging models. So that's why we thought this was a great opportunity to bring folks together to talk about it. We are going to cover briefly RHT and access and lead, but then we really want to leave lots of time for discussion. Before we jump into things, want to talk through the sort of housekeeping. So when we think about questions, we definitely want to hear from you. So please enter your questions in the Q&A feature in the chat. And we will stay on top of that. And we have some time at the end where we'll go through those questions. If you have any problems with that, you can go ahead and email it. And you all will receive a PDF copy of this presentation at the end. Allison? So as I mentioned, we're going to talk about the converging opportunities. You're going to hear some policy updates from Sachs, and I'll get into the introductions in a second. We're going to walk through just briefly the Venn diagram of access and lead and RHT, and then we'll turn it over to our panelists who are living and breathing this work right now to hear about what is their thinking, what are they seeing nationally, and how do we go about working together to maximize this opportunity for our communities. Next. Okay, so wanted to do a nice introduction here for our panelists who, again, we have here David Gross, who is a consultant with Sachs Policy Group. He is bringing national experience, deep policy, and regulatory background to the analysis of what RHT means to New York and the ability to interpret those signals, the CMS signals that we are seeing on the landscape. So anxious to hear from him today. We're going to hear from David Bender, who is the Chief Executive Officer of the Community Health Center of North Country, who's navigating these changes on the ground as an FQHC leader. But he has a background not just as the leader of an FQHC, but he's also been the COO for St. Lawrence Health System and also worked at UPMC. He's had a lot of experience in rural hospitals and rural health systems and how they're managing through the changing times. And then we have Tom Mixner, who's our Principal and Value-Based Care Enablement Finance Lead at Cope Health Solutions. And he's focused on financing models and risk strategy, as well as capital deployment. He is a former CEO for multiple health plans, including Health First. So really brings a good plan perspective. And Eric Schell is with us today. He's the chairman of Stroudwater Associates. I know many of you know him. He's got a long history of advising rural hospitals and rural health systems, and we've worked closely with Eric in the past. He's going to be bringing some of his insights around his experience and what's happening across the nation, and also talking specifically about not just operational stability and changes that are needed, but also from a financial sustainability perspective, what he's seeing as organizations are moving towards value-based care. And then James Sinkoff is with us. He's the Deputy CEO and CFO at Sun River, and he brings the perspective of a very large and successful FQHC safety net with both the rural and urban footprint, and is doing some really incredible work with his rural health system partners. So anxious to hear about that work as well. So we will launch with David Gross and the Sachs Policy Group update. David?
Great. Thanks, Bridget. And again, I think the meat of this presentation is going to be our panelists giving their experiences. So I'll move pretty quickly through the policy, but I want to help frame why this is an interesting time for rural health. Next two slides, I think. One more, please. All right, perfect. So the way, because rural health has been, on the radar for a lot of years. It's known that in rural health, the providers are struggling. So I think an interesting question, which we as the group were thinking about before, is like, why now and what's different? So it feels like there's three general trends that we're seeing that kind of Bridget will dig into operationally. And the first is there's a lot of changes happening on the financial side, right? We all know what happened last summer with the passage of the One Big Beautiful Bill Act and the downstream impact that we're expecting it to have. And in particular on the Medicaid enrollment, it's going to be harder for people to stay on Medicaid, which is going to result in people coming off of the Medicaid rolls, which in places like rural New York, where already margins are tight, that will just make it tighter. I think the other side of it, and I'll spend a little more time on it, is in addition to that, there is this kind of opportunity where a lot of money is going to be flowing into New York to invest in rural health. It's focused on technology. And that was one of the pieces that the federal government built into the bill. So there's both these cuts and this opportunity to invest more money in technology. And that's what will be rolling out in New York over the next few months. So that's a big piece. I think the two other aspects that are lining up here is one, people, I'm sure a lot of you are familiar with Medicare ACOs. They've been around for a number of years. What's interesting is there's a model that's called REACH. It's the more advanced, higher risk model, which is ending at the end of this year. And there's a new model that's going to be taking its place. And the details are still forthcoming. I'll give you a few highlights as to what we know. But what's interesting is the model, at least the way it's being described, is very forward thinking around rural health. So to the extent these rural technology investments support sustainability, ACO might be a good chassis to kind of move that forward. And then more broadly, I'll talk a little bit about big picture. The federal government, I'm sure a lot of you are looking at the news, is very interested in technology, very interested in AI. So it's a trend that we should expect to kind of keep seeing over the next few years under the Trump administration. Okay, next slide. So just to talk quickly, Rural Health Transformation Fund, I assume many of you are familiar with it. It was part of the One Big Beautiful Bill. It was $50 billion across the country over 5 years. Every state put in applications. New York was awarded $212 million. For some of us, that was a bit of a surprise because we thought that New York would get less because New York is New York. Nonetheless, it's a relatively reasonable amount for New York. And what's really interesting is there is a lot of pressure on states to spend this money really fast. If you don't spend it, at least kind of allocate it for a specific provider. And because that will in part determine how much you get over the next 4 years. Certain states have already started releasing applications to access that money. New York has not. So kind of every week or every month that goes by with New York not releasing information about how this money will be distributed, I think just it highlights for everybody how much pressure there will then be once this information is released for the state to figure out how they're going to allocate it or distribute it, because they're going to want to tell it to the feds as they put in their application for the second year. So that is coming up, I would say, almost any day. I know the state is trying to still figure out the parameters with CMS, but we don't have details as to when the NOFOs, RFPs, however they decide to distribute it, are going to be released. Next slide. And so just a slide on, well, okay, so this money, this $212 million is going to be available. How is it going to be invested? So we know the state put in an application with 4 buckets. I think really the first 3 on this slide are the interesting ones. The first one in particular, it's Community Health Integration Fund. It's basically trying to pull together new groups of providers in rural communities to work together to stabilize finances. And it's interesting because it doesn't have to be led by a hospital, but it has to include a hospital and show that the whole project helps the financial stability of one of the rural hospitals. So in a way, it's pretty similar to those of you who paid attention to New York's safety net transformation pool. It's pretty similar to that, not the exact same, but it seems to have an opportunity for really creative new partnerships in rural communities that may exist already today or may not, and this is an opportunity to set them up. So, and then the next ones, right, the second one, you can see the amount of money involved. This is really about PCMH, but it's not just about helping primary care practices become PCMH certified. It's actually also about taking existing PCMH practices and pushing more technology into them. So it's an interesting opportunity that it's not just for people trying to get up to PCMH in the first instance. And then the third bucket is about technology innovation. They called out things like virtual care, remote patient monitoring, and cybersecurity. So just to kind of flag how I think about these buckets is the first one really is about consortiums and groups working together, recognizing that there has to be this thread here about rural hospital financial stability. The second one obviously is very focused on primary care practices. And the third feels like it's flexible. It could be open to lots of provider types, and the details TBD. I'll just make a comment also about all of these is, one of the things that we don't know is even what the process is going to look like, how you access the money. Interestingly, in the budget, the governor actually asked for language that lets her have lots of flexibility for distributing it, meaning she doesn't have to go through a traditional RFP process. So we'll see over the next few weeks what that looks like as the budget gets finalized. But again, I think it all goes to that when this money is made available and the state figures out how it's going to distribute it, it's going to go fast. So it's really important for everyone, if you're thinking about this, start really thinking about what you would want to invest in, because you're not going to have a huge amount of time to develop proposals once the kind of NOFOs, RFPs, whatever it is, gets released and you have to then submit your interest. Okay, next slide. Okay, so the first piece, right, that was all about money to invest in technology. And I think a big question, of course, is, okay, so you invest in this technology. What does sustainability look like? How does it align with other things that you were doing in your settings that align with that? So flagging briefly what's going on in the ACO world. So again, CMS remains committed to ACOs. I think it was interesting when the Trump administration came in, a lot of us thought there'd be a really big push to move everybody into Medicare Advantage. And in a sense, it's generally supportive of Medicare Advantage, but probably not as aggressively as maybe we would have thought. There's actually a lot of pushback on Medicare Advantage rates. And at the same time, there's been a lot of support for ACO, and especially the administration is really interested in this new model called ACO Lead. And I have some details here. I think the real details we expect to be released pretty soon, but most importantly, they're talking about it being an opportunity for rural health that hasn't existed, including some upfront payments for rural providers. And the model itself is designed in ways that they really want providers to get engaged in it. It's 10 years long. They're changing the way the benchmarks work to make it more financially sustainable over time. So those of you who've looked at the model, maybe you're in a low risk model, maybe you looked at it and decided it wasn't for you, this might be a really interesting time to re-engage, because there is a whole new model coming out and it will go live January of next year. Okay, so one more slide. And okay, so and this is the last point I want to make is that behind all of this is a federal government that is really, really interested in technology adoption. And it's not just about healthcare, right? This is across all sectors. And it's both that they're interested in technology adoption and they recognize that if they're not careful, technology adoption just leads to bloat, right? You all have implemented technology that I'm sure you put in place, and then you realized it didn't actually help you reduce your workforce and it cost a lot more money over time. The government is aware of that. And part of, I think, all of these is to think about ways to not cause that to happen. So there's an interesting model out there called Access, which is all about AI-enabled care management and pushing that into the Medicare sector. Some details on the slide. I just think what's really interesting about it is the rates are really low. So it's setting up a system where the federal government's saying, look, we want you to invest in technology. We're going to find ways to pay for it, but we're not going to pay a lot, which means if you want to get involved in this and kind of think strategically about technology, you have to do it in a way that really does reduce your costs, not just adds to overall system costs. So that's the third thread, I think, behind the money that's being available in rural health and kind of the new ACO opportunity. I spoke really fast, but I think, Bridgette, I'll move it back over to you.
No, thank you so much. That was really helpful, David, and I think a good overview. We, we think a lot about, I know having sort of cut my teeth in New York, we think a lot about the different opportunities as they come through. And we really do, because of the way they come out, we're so often needing to, live in the moment for this grant, for this opportunity and spend it. And you don't have a lot of time, right, to think about strategy. And I think part of why we wanted to bring this webinar together is to really kickstart providers and community leaders into thinking about this is maybe a one-time opportunity where we have the ability to look at the intersection of both the state and the federal policies as they're rolling out in these funding opportunities, and they're kind of aligning nicely for once, from my perspective. And Alice, if you can go to the next slide with the diagram on it. So we talked a lot about these sort of independently, but when you think about them as a group, rural health transformation dollars are going to give you an opportunity for, risk-free capital, right? Build the systems, the workforce, the technology capabilities with these funds that you're going to need into the future. And when you think about access, access is the payment mechanism that's currently been brought forward by CMS to help to pay for the technology enabled care. And we know that health plans have articulated that they intend to also follow suit and support these in technology enabled care programs, as long as they're providing value, right? And so we do see a roadmap where some of these investments were in the past, it was kind of like you had a grant, you did the program, and then, good luck in the future trying to get a contract with a health plan that was going to pay for that was going to pay for it ongoing after the grant ran out. I think what we're seeing here is a migration towards recognition that doesn't work, and there has to be an on-ramp for true transformation to fund it long term. And so if you haven't taken a look at the details of the access model and what's going to be covered and what's not and how to bill it, you absolutely should. There are a lot of opportunities here to think about your partnerships. And granted, there's also a lot of rules, around who can't be an access provider and who can, but this is allowing you, especially in the rural communities, to begin to deliver clinical programs at scale. And then comes along LEAD, which is really the long-term sustainability model, because as David pointed out, the access payments won't be a lot, right? That in and of itself is not going to transform healthcare. It is just paying for one piece or one leg of the stool. And we really need the broader value-based construct in order to pay for things that need to be different in the rural communities. And so When you think about LEAD, and it does have the rural provider add-on, which is very helpful. You think about delivering care in a rural community is not easily done in a fee-for-service model with it belly buttons through the door. And there are just some essential services that need to be provided. Care panels need to be much larger. Primary care providers end up needing to carry much larger panels, which means you need a care team that can deliver services and be able to support that provider to carry those larger panels. You need to have a good, solid a population health management technology infrastructure that's going to allow you to parse the population and do the right care for the right person at the right time. And the critical access hospitals and the rural hospitals are a key partner in being able to deliver those services for acute care, and getting patients to those services in the right way and at the right time will help the hospitals to be successful, but also, again, provide for long-term management of the population in an effective manner. And how those networks come together in order to support that population, I think, is really where the crux of the opportunity is that we're starting to see evolve nationally, and is something that I hope that we get the opportunity to sort of touch a little bit on with some of our panelists today. So that is how we're seeing these funds come together. Think of rural health transformation, paying for building the house, and the access model helping you to furnish and get into all of the rooms, and then LEAD being, your long-term mortgage that helps you stay in the house for 10 years, right? So kind of my sort of pea-brained approach to thinking about how to think of these things as they overlap. Alice, you want to go to the next one? So I wanted to leave lots of time here for panel discussion, and then we'll get into some questions. And so, you know, how are we thinking some of the stuff we want to cover? How are we thinking about organizational readiness, right? So what is the data infrastructure that you currently have, whether you're an FQHC, a rural health clinic, or a hospital? What is the quality reporting and capabilities? What population health management capacities do you have, and enablement technologies? What are the weaknesses of your basic, block and tackle operation and management services? When you think about regional partnerships, have you thought about regional partnerships and what that could mean? So how hospitals might actually come together, not in merger acquisitions, but come together in clinically integrated networks, or to create opportunities for buying power and contracting and enlarging the population so that your population strategies make sense, right? That you've got enough volume. And how do these relationships value sort of the core business models of a VBP type of an arrangement? Then we can't forget Medicaid. So we right now, some of what we're talking about is mostly federal, right? But the Medicaid strategy matters, and figuring out how you align the financing, the capabilities, the infrastructure that you need, not just for your Medicare population, but also for your Medicaid population. And I know most everybody thinks about that, especially in the rural areas. So I'm curious to see what folks are thinking. And then accountability and sustainability, talked a lot about what are the operational workflows and the workforce. So as you think about your workforce, it's not just about, nurses and doctors and access associates, right? It's really what is the pipeline that we can build, and how do we create a workforce that's resilient and has the ability to think about sort of future models of care, and how we're building the future workforce that is going to be part of that sustainability plan, and reinvesting beyond sort of this funding period. So those are, some big concepts out there. Really curious to see what other folks are thinking, and wanted to sort of jump right in, I think, to the panel. And I'm going to lead off with Jim. And Jim has done some really incredible work, and I'm anxious for him to have an opportunity to share about how he's been partnering and how he's been thinking about rural health and their clinical models. So, I think many providers are facing immediate challenges. in workforce, service line closures. We know maternal health is a major problem, lack of financial stability in sort of all sectors. And so from your perspective at Sun River, how do you balance the day-to-day operational challenges with the longer term pressure that you know you have to be sustainable and to provide sustainable care to your communities? And how are you thinking about that rural health transformation support is sort of growing those important strategies?
Good morning, everyone. Thank you, Bridgette. So just a little tongue in cheek, the idea of balancing the day-to-day operation post-COVID. From your lips to God's ears, as they say. So those who are familiar with Sun River know that we have sort of a bifurcated service area from rural and urban. So I'll just focus on the rural side of our service area, which ironically also is sort of the eastern part of Long Island in the North Forks, which is the second largest agricultural district in the state of New York. Obviously, in the entire upstate region, Finger Lakes region, and across New York from east to west, it's the largest agricultural region. So some of the things that we contend with and where we think rural health funding may avail itself is we are confronting OBGYN deserts. We still have hospitals that are delivering, but recruiting and retaining OBGYNs and midwives into the rural communities is becoming more difficult to do. There's the typical labor problems in terms of price and recruiting. And I would say that recruiting into rural areas, and I'm sure this is similar to others' experience, is actually more difficult in many ways than rural areas. They're a different set of competitive pressures. But we talk about food deserts, in lots of different ways, but I think it's very real across our country that we're starting to see women's health deserts, whether it's OB or GYN. It's very hard to recruit. So we do see an opportunity to start linking with some of our rural hospitals in Eastern Dutchess, Sullivan County, Orange County, if you will, to begin to think about how we look at cross-coverage arrangements, how we look at sharing resources so that we can secure and retain providers and make it a worthwhile endeavor, knowing that there's a shrinking birth rate in a lot of rural communities and an aging population, which I'm sure is reflective of many of your communities. So that is one area that we're trying to exploit, if you will, with some rural health funding and then adding the technology layers. Let me pivot just a little bit to another example. So we have been in Medicare shared savings for many years. We were in the REACH program. We left the REACH program. That's for a different time, different topic. But one of the issues that we really are finding in the rural communities is the use of alternative technologies to identify and engage with patients. There are many technologies out there that have become more sophisticated in terms of identifying the best times to call seniors at their homes when they will, in fact, pick up the telephone. This is how sophisticated AI is becoming. This is how sophisticated, without judgment, the Palantirs of the world are becoming in terms of both, direct cost data, but indirect behavioral data sets. In other words, drawing from sales receipts from the Walmarts and from the dollar stores. This data is now actually available. It is public facing and it can be harvested. So it becomes a very interesting opportunity to think about technology and how it can enable a way to break down the typical ways or the historical ways in which we've outreached to our patients. So what I would say, Bridgette, in summation, because there are others that should speak on the subject as well, of course, is that we're still contending with the day-to-day as a primary care system. we're still contending with the fundamental issues of breaking down barriers to access. But within the value space, we've invested heavily in our infrastructure, and I think the rural health transformation grants provide an additional resource to enhance on that infrastructure that's been built.
I love that story. I love how you're thinking about it from the standpoint of, I know that there hasn't always been sort of smooth relationships between some of the rural hospitals and the FQHCs, and some of that just has to do with the way that sort of funding roles and geography span, et cetera. But to finally be able to see FQHCs and rural hospitals partnering together really closely and leveraging the capabilities of both to their maximum is impressive. And I think, what you've been able to do for maternal child health and stabilizing some of your critical rural areas, working with those hospitals and leveraging, some of the benefits you get as an FQHC for recruitment and retention and, tort coverage is just, I think, a monumental achievement. So congratulations on that. Love it.
Thank you.
David, just dying to hear from you from the standpoint of what are you thinking? You've worn both hats, and from your perspective now leading the FQHC in North Country, what are the biggest structural challenges? How are your providers thinking about this right now? How are you positioning yourselves? What do you hope for?
Yeah, thanks, Bridgette. It's nice seeing you again. We serve a two-county area in the far north. Both counties border on Canada. There's 5 hospitals in the area. Over the last 10 years, 4 of them have been at extreme risk of closure. One is currently in bankruptcy itself, and so the idea of structural challenges, love them or hate them, you need hospitals. We have done a pretty good job in the area of primary care recruitment. A lot of it has been not just physicians, but the PA and NP level, which really does sort of push even more the need for good specialty care, and coordinating the specialty visits has been an ongoing, just constant struggle. I think as we look to how to improve on some of these things, the sustainability of the hospital systems is important. Obviously, it's not anything that I can focus on right now. But adequate care, both at the primary and specialty level, it sounds basic, but it's a huge challenge for us. The incentive payments, the kinds of things we talked about at the beginning with David, that's about 2% of our revenue base, and that's a lot better than 0%, but it's not a solution. We need better volumes, and to get better volumes, we need better operations, and for better operations, I think we need much better enablement of, charts and referring charts and getting the simple stuff that in theory AI and maybe Access can really help with a lot. We need to learn a lot more about it though. So, it's kind of a light touch that David pushed on the changes of the big, beautiful bill. But when we have $180 visits getting turned into $15 visits because of the lack of Medicaid coverage, it's a terrific challenge. So we don't want to be in the same boat as some of our local hospitals, but we got a lot of work to do. So I'm eager to hear from everybody on this call. That's what some of the direct approaches might be to get us where we need to be in the next year.
Yeah, and when have you thought about networks and the strength of networks? Has that been anything in your wheelhouse, or have you been mostly focused on the operational challenges?
Both. Frankly, our potential partners, the bankrupt place, we've had a lot of discussions and they have a hard time responding right now. And the other local hospitals tend to be focused much more on their corporate parents, which are 4 hours away. And I bring that up only because I think that's what a lot of our rural counterparts are seeing. We do have a good IPA of other similarly sized and minded FQHCs with a lot of the same problems. So I think it's an angle to work towards, but I don't expect immediate relief from that.
Thanks. And is there an ultimate Is there an ultimate success factor you would like to see in your communities come out of the funding opportunities that are out there right now?
I think I don't mean to be doom and gloom here at all, but we've all got to focus on survivability. And yeah,
Yeah.
right now we're in good shape financially, but I am very concerned about 2027. I think every one of my counterparts feels the very same way, Bridget.
Yeah, no, thank you. And so, that leads us to a really good, and thank you for being so open about your challenges. There's certainly, once we have heard, this gives us an opportunity to hear from Eric. Eric, can you talk to me a little bit about, from your experience, working across the country, and what you're seeing as you have led turnarounds and really consulted on financial stability, challenges and parameters for rural hospitals. Can you tell me what you're seeing, what you believe are some of the capabilities that are going to distinguish um, hospital systems or networks or clinically integrated networks in being successful?
Bridget, that was a huge question you just
That's a
asked,
huge
but
question.
that was impressive.
I lofted that to you because I know you can hit it out of the park.
Yeah. Well, good morning, everybody. Nice to be invited to participate in this. I grew up in Genesee County, New York, so I'm an upstate New Yorker, and for the last almost 20 years, I've been participating with all the critical access hospitals in quarterly meetings in Albany, New York. So I have a decent lay of the land of what's going on in New York. What I see the greatest opportunity for rural hospitals is not to do what most are doing, which is to figure out how to cut expenses. What I've found in rural America is the greatest way to improve performance is recognize that significant count of population leave our rural communities to access care in the big cities. And if we could figure out a way to lock down or reduce outmigration, it is a tide that lifts all boats. I live in Portland, Maine now, so I can talk about boats. And so it's a tide that lifts all boats. And studies show that for rural hospitals, incremental volume on a 90% fixed cost or step fixed cost base is a 90% contribution margin. And therein lies the opportunity. And so we talk about cutting expenses. If you want to cut expenses, improve efficiency through growing volume and reducing unit expenses. So that's the opportunity I see. And how do we do that? I think so many people, so many hospitals, they start thinking of their community as a patient. A patient reduces the funnel size into our healthcare delivery system by probably fivefold. Instead of thinking of our community as patients, let's start thinking of them as people, as community, right? And what that means is how proactive are we in embracing our community as people rather than patients? The funnel has just grown. It's significant now. And what does that mean? And I like some of where the transformation funding is going in New York, which is the patient-centered medical home. Whether it's you designated or at least you create the functions, but it's that proactive outreach, getting patients in. Where are we with annual wellness visits, chronic care management? Where are we with annual physicals and well child visits? How proactive we in thinking about that? To me, that's the opportunity. I see a lot of, I get a lot of calls from reporters from Modern Healthcare and others, and they want me to give a doom and gloom story for rural America. And I just can't do that because I see, as I travel around the country, so many hospitals that have taken on an abundance mindset of growth and investment and seen their financial performance go from tanking to thriving in a matter of a year or two with this proactive outreach. So I'm, David, I've got a different approach, but it's what I've seen at work out there. Bridget, now your question about what are we seeing around regional alignment and organizations coming together. I think that starts with this question of why that's happening. And again, I do like that New York has put a bunch of dollars into this network integration. I look at the fee for service payment system, right? Price times sick care volume is equal to revenue. And I look at that and look at the, if we go with the premise that form, what we look like is a direct result of the functional imperatives of a payment system. In the fee for service payment system, there's three functional imperatives. Managing cost is one, increasing sick care volume is number two, and number three is managing price, negotiating higher price with insurance companies. Those are the three functional imperatives, none of which requires an integration of other entities. Now, payment is evolving towards value-based payment for all the reasons that Bridgette just talked about, David just talked about over time, and it's inching. The functional imperatives of a value-based payment system completely change. We have to start thinking about, kind of aggregating resources. Think about tertiary care, rural health care, primary care, specialty care, health and diet, community health, post-acute care. We also, so aggregation of delivery. The second piece is we have to pull together to aggregate population to diversify insurance risk. So these functional imperatives of a payment system that's no longer static in fee for sick care require an aggregation of organizations. And so what we're seeing around New York is we're starting to see organizations come together. I like the fact that their community health centers are working with and partnering with rural hospitals. And as one piece of that primary care to rural hospital care. So I'm starting to see that. I'm starting to see that all over the country. The FQHCs coming together with rural hospitals. Years ago, I was working with a health system, a critical access hospital and a community health center that was the Hatfields and McCoys of North Dakota. And what we ended up coming up with is we called it the interdependent model of alignment, where we created a contractual relationship, a governance relationship, and a functional relationship that allowed those two entities to come together on behalf of their community, leveraging, and I think somebody said it, maybe it was Jim, leveraging the best features of the community health centers and the critical access hospital to benefit their community. It was a great thing. Anyway, I've just said a lot. Bridgette, have no idea what if that was at all on target, but
No, I think that's right, and I think that's what the team at Cope Health Solutions is seeing as well. From the standpoint of we are seeing that the clinically integrated network is way more important than it used to be for stabilization, because it does allow so much flexibility around contracting and creating shared purchasing power and things like that, as well as having the success of those SINs being sort of grounded in what is the data platform and the management services platform that's helping to operationalize that work, so that you're efficient at it. Because just because it's value-based doesn't mean that everything is covered, free and in perpetuity, right? You have to have good management infrastructure in place and a way of navigating both the financial systems, the contracts, as well as the populations. And I think, we're seeing that in the West. We're seeing, with some of those organizations that are coming together. But what I've seen that is not happening as much, and I think New York has a really great opportunity to bring this home, is a lot of those networks are much more like heavily weighted towards just the hospital, right? And I think that what New York really has strength and ability to do, and I think California as well, and that's why we're seeing it there, is bringing the marriage of the FQ and the rural hospitals together, because it really does create this sort of lattice of strength that is evident in like the work that Jim's doing with Sun River. So Tom, you're the finance guy, right? You're the CFO. You're the person that everybody wants to court. Tell me what you think from the standpoint of, how do you think the health plans are thinking and responding, and what are your thoughts in general around rural health transformation, and where should where should our providers be focusing? And tell me a little bit about what you think about networks, and are they important? Are they not important from a plan perspective?
No, thank you, Bridget. And as I think about this, it's funny, the chart that was shown on the previous page with the VBC in the middle. I mean, VBC is only the end game that works if all the other investments and infrastructure changes actually solve some of the rural health issues that we're talking about here. So I think I start there because I think the most important thing to me is not, you can always come up with a great contract that works, but it's starting with a data-driven approach to what the issue is that you're trying to solve for. I mean, what each of my co-panelists was able to do is succinctly state, like, okay, I have this issue in my region. I'm trying to solve for this. I think it starts right there because it's not a cookie cutter approach. Each region is different. Each region has their own issues that they're trying to solve for, so the tactics may be different. So I think I'll start with, people need to continue to enhance their ability to really identify what their issues are. And as we move forward with this, I think building on that, being able to really track on, okay, are we moving the needle? Because I mean, as we all know, when it comes to like innovation or new programs, things don't always work. Like it's one of those, like we're going to try things and some will work and some will not. That always happens. So how do we continue to track on the right metrics, work together, and understand when something's working, when it's not, so that we can collectively embrace failure when it doesn't happen, and move in the direction of like, let's continue to invest in the things that are working and not in the other ones. I think, and I'll shift a little bit. I mean, I think what's really important, because I've seen a lot of attempts to make this work and bring, provider organizations together. I think from a plan perspective, I'll stick with the plan perspective and not talk about like ACO right now. I think from a plan perspective, I think what's most important, and again, not the same answer for everybody, but there has to be, the organization that's coming together has to be able to have a holistic conversation about moving the needle on total cost of care, truly solving the issues. Because if we continue down the road of having like fragmented conversations where you have somebody at the plan speaking to the hospital and somebody speaking to the FQHC where the incentives aren't aligned properly, then it's all going to fall apart. So I think it's very important for, as people build out their networks, just to think about, and again, probably won't be the same answer for everybody, but how do you actually build a structure so that you could have a strategic, holistic conversation with the plan, so that ultimately you could figure out like, okay, we're paying for improvement in total cost of care, improved outcomes, improved access, and then, the provider entity could figure out like, how do they hack up whatever money's there? Because again, I keep coming back to, VBC only works if we actually are successful in actually solving some of the issues that we have here. So, those are the initial thoughts that come to mind, Bridget. I'm not sure if I answered all the questions that you threw out there because it was
Yeah, no, you did a great job. You did a great job. And I also think that when I think about the health plans, they've got to have networks that their patients can get access through, right? And I think that's one of the things that you're also saying. And in doing that, I know in Pennsylvania, the payers came together and they were working to try to come up with a transformation model. And that failed. And it failed because it was very focused on just in time fee for service payment, and not necessarily all of that transformation work that has to happen in order for that the shift in both care delivery and the value of the care that's delivered, and then getting paid for delivering that in a different way than you would in an urban setting potentially, or a more populated area. So I think there's lots to learn from what did and didn't work, and there were certainly things that did work, that I think hinged on providing the right data so that they had a good understanding of their patients and their patient base, and how to outreach earlier and get at sort of rising risk. But I think it was just proof positive that fee for service transformation isn't really transformation, and that you really have to think about the broader population and value-based care in order to get to transformation. So super helpful. We have talked a lot.
Sorry, because when you brought that up, I mean, I think what's important to not ignore though too is that the fee for service is important, because the funding's there right now, so people can tap into the funding. eventually for this to be sustainable, when the funding goes away, there's going to have to be some kind of upfront payment. That's the issue with all these things, right? You make the
That's right.
investments upfront, they cost money, and then it's hard to wait until the back end. So I think, again, it keeps coming back to the data-driven approach, understanding what's working and what's not, because when the funding goes away, at some point, the plan's got to be committed to, like, okay, yeah, I'm confident this works, so I'm willing to pay the money up front and then have it settled up on the back end. But that's the problem with all these innovations, is that, like, the money has to be invested up front, and it's hard to wait for the outcome. So that's I think, in order for value-based to work, there has to be a sustainable fee-for-service component to the things that are working once the funding does go away as well.
That makes really good sense and sort of leverages, I think, Eric, what you were saying with respect to, living within the fee for service payment in and of itself. And one of the levers is cutting, right? Which is really not the right answer. Jim, you had raised your hand, and I know that you guys have struggled and you've done terrific with some of your transformative fee for service value-based care work. What are you thinking?
Well, so I wanted to marry a little bit of Eric's comments with Tom's comments, because I think there is a real pain point that I think Tom's getting at and Eric's getting at. So, the fee-for-service system incents us, as Eric is noting. We all know this. So in order for the hospital system to decant med-surg days, it has to have a way to then offset the cost structure, whether there's long-term bonding, whether there's long-term pension payments, all of the structural issues of cost. So partly what the community has to do to come together is recognize those realities, because as med-surg days are decanted into the community setting, into the primary care setting, into other settings, that cost shift from a community-based perspective then needs to reside within the value-based construct. And therefore, the plan's role, and this is getting to Tom's point, the plan has to see this as a long-term investment in that transition over time. Because without that long-term funding, after the rural health money evaporates, costs have been moved. They have not necessarily left the community, which is Eric's point about abundance. Don't want to see the community suffer, but the institutions themselves have to contend with a cost shifting at the community or the population level. And then how does the data, how does the information, how does the financing system help to inform what that long-term shift looks like? So I thought what they were saying was so valuable, and I just wanted to kind of add a little bit of, kind of the meat between the layers of the bread, if you will, to what the two of them were getting at.
Appreciate that. Appreciate those insights, and thank you to the panel. Alice, I'm not sure, we can open this up to questions. I'm not sure if there were any that came through in the chat while we were talking. I'll give it a second. I guess it's Alice or Andrew. I'm not sure who was following.
Which I'm not seeing any on my end. One, though, that came through from the attendees prior to registration or upon registration, one attendee asked, to what extent and how are managed care organizations involved in the state's approach?
Yeah. Dave Gross, what do you think?
Yeah, my sense is how this came together is the state had a process where they did go out, they asked a lot of both individual providers and groups to help them think about it. And then it went into a bit of a black box. And then there was a really last minute scramble to put it all together. So I have a feeling that that's what it felt like was going on. So I think they had everyone's input. I don't know how much of it was kind of last minute conversations, specifically with plans. I never got that feel. So I think they gave input, but the same way a lot of other coalitions did. I think the big thing is when you think about from a state perspective, what they were trying to do. I think they were trying to balance two things. One is to get as much money as possible to align with the MAHA goals. And the second was, I think, and you see this with that first pool, is to align it with things that they're already doing, especially the safety net transformation money, which already have been available, because I think they're worried about how much money they can use for new infrastructure. It's not a lot of infrastructure money from the state side, so trying to line up what they do with what's already funded or supported at the state level.
Makes sense. That's very helpful. Thank you. Well, I want to thank everyone today for staying with us. I want to thank the panelists for taking time to join us and share your thoughts and your expertise and your wisdom. You guys are an incredible group of folks. So pleased to know you. And if you have any questions, you can feel free to email us, and we will do our best to try to help you navigate to the right solution. So have a wonderful rest of your week, and enjoy the day.